Yeah. Good afternoon, everybody. Please grab your meals and find a table. We'll start sort of in 2 minutes. Doesn't have to be that quiet. I just said get your food. You can listen to me attentively in 2 minutes' time. Okay, I think everybody is seated. Then I'm going to say good afternoon, everybody. Welcome to our symposium this afternoon, HIV in Canada, the past achievements, present realities, and future visions. Oh, I'm doing this myself. This is supposed to be a TED Talk format, and you can see I'm already lost to what is my purpose here. Of course, Halifax, Chipuktuk, which means Great Harbor. I would like, of course, to start with the land acknowledgement. For more than 13,000 years, the Mi'kmaq have called this beautiful land home, enriching Nova Scotia with legends, art, music, spirituality, history, and language. Halifax, Chipuktuk, is located in Mi'kmaqi, the ancestral and unceded territories of the Mi'kmaq people. This territory is covered by the treaties of peace and friendship, which the Mi'kmaq, the Wallace, took away and the Passamaquoddy people first signed with the British Crown in 1726. The symposium is brought to us by Gilead Sciences, and a special thank you to Neil Button. He is the Associate Director of Marketing that has worked so hard to get all the speakers in line and arrange for the TED Talk format. So if I fall over my shoes today, it's his fault. You can hear the orchestras warming up. Nova Scotia is situated here on the rugged east coast of our country, where the water is always cold, but the people are warm. And someone is always playing an instrument somewhere. Because fog and fiddle music roll in together in this place, I thought I'll use the theme of an orchestra today, because we all play a pivotal part in this orchestra, in the towns we work in, the cities, the provinces, but together as a unit, we move our country forward to ending this epidemic or the WHO's 95-95-95 requirements. So here's our orchestra and our 4 virtuosos that's going to present today. Unfortunately, Sasha, behind the kettle drums there, got very sick last night and is not with us. I hope a speedy recovery for Sasha. And so the symposium will be a little shorter. You'll be happy to hear that. I'll be your conductor today, but I won't be that Queenie. That is like way too Queenie. And I don't know, I obviously didn't get the memo because that dude is wearing black and has hair. So I don't know where that picture comes from, but my name is Josh DeWitt. I'm a family physician, HIV primary care physician in Vancouver, and an associate clinical professor in the Department of Family Medicine at University of British Columbia. So I'll guide us along here today. Our learning objectives. First of all, we're going to examine ARV innovations, evolution, and revolution. We'll talk about reaching 95-95 targets. Well, we won't, because Sasha is sick, I just told you. So we incorporated this with Nadine's talk. Thank you, Nadine, for on the spur of the moment, putting a whole presentation in her talk. She will talk about discussing the disproportionate impact of HIV, and we'll end with reassess the transformed perceptions and expectations of people living with HIV at risk or at risk for HIV. Here is our faculty: Dr. Steve Shafran, Nadine Sukamani, Sasha, which is not with us, and Patrick O'Byrne. Did I get it right? O'Byrne, thank you. And here's our conflict of interest statements. But before we start, of course, you've already seen there's QR codes on your table, so we're going to have a Slido. So to join the Slido, please look at your QR code, and the side that has the learning objectives on it is the QR code we're going to use. So please use the side with the learning objectives, scan the QR code, and here's the first question. Thinking back to 2020, do you think we were on target to reach our goals for ending the epidemic or the 95-95 targets? So if you can answer that for me, and we'll give you a minute, and then we'll see what Slido tells us. If you think 5 years ago, were we on target? And it looks as if it's between a 6 and a 7. Well, it's between a 6 and a 7. So maybe a score of 6.1. We were at a 6.1 to reaching our targets. Now, of course, I'm going to ask you the next question. But this is only for Canada, because if we think of Trump and US aid, of course, it is a disaster where we are in the world. If you think just in Canada today, are we more confident? Are we the same? Are we less confident than a 6.1 at the moment of reaching our targets? If you can enter that into your Slido answer for me, please, that'll be great. And I'll see what we think. And I already see that 74 of you have answered. That is just like super. Let's see where we land. There's clearly some pessimism in this room, which, of course, none of us can help, because there's global anxiety regarding US aid has been stopped. But in our country, we're not impacted by that, but clearly we are all experiencing that. So, without further ado, look at him rising up so macho behind his cello. I don't know why I had to be so queenie. Dr. Steve Shafran, I'd like to invite you to come up. Steve is an infectious diseases specialist in Edmonton, Alberta. He has done HIV, Hep C, Hep B treatment for more than 30 years, has published more than 100 papers, is an absolute expert in his field, and I'm very happy to introduce Steve and ask Steve to give us his presentation.
Thank you, Josh.
Thank you, Steve.
Well, thank you for the kind introduction and for the invitation to address this conference. It's always nice to be in Halifax. So I'm going to walk you through fairly quickly a little bit about the history of HIV therapies over time, with a strong historical perspective that's somewhat personal. So I take you back to the year of 1982. Yes, wasn't that nice? 1982 was the year that the term AIDS was first coined by the CDC, 1982, before the causative virus HIV was even yet discovered by the group at Pasteur in Paris the next year. And in 1982, we did not have cell phones. We did not have internet. And our great technology was a one-way pager. That was advanced technology then. And of course, all our x-rays were on film. They were not digital. And it was in the fall of 1982 when I applied to become, I was a resident physician, and I applied to train in infectious diseases. And then in 1983, when I actually started my infectious disease training, that was the year that the group at the Pasteur discovered HIV. But amazingly, it wasn't until 85 that we even had a blood test for it. And we certainly didn't have any therapeutics. In the early days of HIV, they were really very dark days, very dark days. We admitted people to hospital with various opportunistic infections, a lot of cases of pneumocystis pneumonia, people who had CMV retinitis and were losing their sight, and people who were severely wasted, like this poor young man in this photo that is a real and not a contrived photo. We saw a lot of death of people, most of who were really quite young. It was a very, very sad time. And as clinicians in the field in the early days, we actually spent most of our time diagnosing and treating the opportunistic infections that occurred in people with advanced immunodeficiency, because we were not yet able to treat the HIV infection itself. And then in the fall of 1986, when I was a newly minted specialist, just starting independent practice, I was in New Orleans when Margaret Fischel from the University of Miami presented the data of AZT to the world. And we finally had a therapy that offered some hope and a very modest survival advantage, but it was the beginning. And sadly, over that decade of 1982 to 1992 in the United States, if you look at the causes of death of young men, from the ages here of 25 to 44, this is an age at which, of course, there aren't a lot of deaths. However, you can see unintentional injuries have historically been the leading cause of death in men, in young men. But over that decade, what we saw is the emergence of the HIV/AIDS epidemic caused a lot of deaths in that decade where we didn't have good therapies for HIV. And it, in fact, became the leading cause of death by 1992 in that age group. So if we go forward now 4 years to the summer of 1996, when Canada and Vancouver in particular hosted the International AIDS Conference. This was the year where there was a radical change in HIV therapy, because up to this point, we had moved on from AZT, but we basically were using almost exclusively monotherapy with nucleoside reverse transcriptase inhibitors, which were providing only modest benefit at most. But this was the year when we finally could tame the beast, and we're our first generation suppressive therapy. And I'll show you an interesting historical video clip.
It's colloquially referred to as a cocktail. It's got to be given every day. The number of pills vary from 6 or 7 to 20 to 25 to 30 pills. It's quite expensive, and it is somewhat disruptive, if not considerably disruptive, of the lifestyle of an individual to have to take all these pills. So the idea that because we have a treatment, it's easy, it's not. The effects are good and favorable, but the treatment is not an easy treatment regimen to follow.
Well, that was Tony Fauci at the age of 45. He's now 84, and he retired at the age of 82. But this is what Tony was talking about. This is what first-generation suppressive antiretroviral therapy looked like. And some of you may know that in the first few days, it was often called HAART, standing for highly active antiretroviral therapy, which was a blatant admission that everything up to then was not highly active. We no longer use that term, but it has a historical meaning. But it was a big handful of pills, and it was taken multiple times a day. There were restrictions on food, and there were drug interactions with other medications. It was very complicated. And also because these early generation regimens were not that potent, and many people had been exposed to nucleoside drugs, and it had a lot of mutations in the RT, the reverse transcriptase part of the virus that nucleosides target. There was a lot of resistance in the early days, a lot of resistance that we had to deal with then.
top story this evening, a landmark treatment option for HIV and AIDS.
The administration has approved a pill that is going to make history.
A 3-drug cocktail into a single life-saving dose. First ever one-a-day pill for HIV/AIDS patients.
It's a fairly small tablet with big implications.
It's called Atripla, the Tripla, Atripla.
Atripla, Atripla, Atripla.
Bristol Myers Squibb and Gilead Sciences have just announced another first.
The FDA approved a landmark drug
for use against HIV.
So there we had Atripla. So we had gone from that massive handful of pills that you saw there to a single tablet regimen, or STR, but it took a long time to get there. It was till 2006. It was the first STR. It was imperfect, but it was the first one. And there was a lot of enthusiasm about it. And many patients were asking about it, even patients for whom it was not suitable because of their resistance profile. But there was a lot of interest, a lot of demand. And for many people, it was a very helpful therapy. And the people who were able to take it, they felt less sick because they were taking one pill a day. And so that took a long time to get there. And Atripla was the only single tablet regimen available for roughly 5 years. And if we fast forward to the present time, there are 11 single tablet regimens that are Health Canada approved. And today in Canada, 87% of people living with HIV taking antiretroviral therapy are taking an STR. That's where we are in 2025. So let's have a look now at 2012. So 2012 was the year that the US FDA approved Truvada for PrEP. And this is another major milestone in the history of HIV therapies. Regrettably, it was 2016 when Health Canada approved Truvada, 2012 in the United States. But PrEP has been a very important step forward because in people who take it consistently, it is extremely effective and the failure rates are very low. And this is our first generation PrEP. And then chronologically, in approximately 2016, I think there was a convergence of scientific opinion around the world that the Swiss were right all along in 2008 when they said that a person with HIV infection who takes antiretroviral therapy and has an undetectable viral load cannot transmit to a partner. And here we are in 2025, and there's been not a single exception to that rule, not a single documented case of link transmission from a person who's HIV positive on suppressive antiretroviral therapy. And this has been very empowering to many, many people. And it's also reduced the ridiculous criminal prosecutions that have occurred in some parts of the world, including Canada. So U equals U is a very important message and an empowering one for sure. So traditionally, we have focused on achieving virologic suppression in our patients. In fact, in the early years of suppressive therapy, starting in '96, that was almost the sole focus. Well, today, it's still necessary. It's still necessary, but it's not sufficient because we want more than that. We want to optimize long-term health and support for people throughout their lifetime because the life expectancy of people living with HIV who take antiretroviral therapy is pretty much the same as the general population. So we need to plan for a lifetime, medically, socially, economically. So I remember in the dark days where we had no therapy, where people were saying, well, maybe I should take my life savings and go on a world trip because I don't think I'm going to be here that long. And today I say, you need to have RSPs like everybody else because you're going to be around a long time. So people living with HIV come in all shapes, sizes, colors, and dimensions. And it's not a one-size-fits-all. We need to tailor our therapies to each individual's specific needs, wants, and priorities. And increasingly, we are able to do that. So some of the things we do is we've generally moved in most places in the world to rapid initiation of treatment, starting antiretroviral therapy as soon as a person is confirmed to be HIV positive with, of course, their agreement to be treated. We have therapies that are increasingly simple. They're way better tolerated. If you look at the discontinuation rates for side effects of modern therapies, they're so much lower than our older generation therapies. Most of our regimens now have very few drug interactions with either other prescribed medications, but also street medications that some people are taking. And our regimens increasingly have very high barriers to resistance, and we see so much less resistance now than we once did. And many of my younger colleagues in HIV medicine know very little about resistance mutations because they almost never see them. And that's okay. That's okay. And of course, we want to improve quality of life and reduce stigma. Well, stigma has been reduced, but it's not gone away. And stigma is more of an issue in some communities than it is in others. And that's a societal challenge. So, if looking at where I think we're moving in the future, if we look at treatment first on the treatment side, and I'll talk a little bit about the PrEP side after, on the treatment side, as I mentioned to you, the vast majority of patients today are on oral therapy, and most are taking a single tablet regimen. With respect to oral therapy, in the not distant future, we will have once-weekly oral options. In the later future, we will have oral options that are dosed even less frequently than weekly. On the injectable side, we have a first-generation injectable option now that is dosed either monthly or bi-monthly. In the future, we are going to have other injectable therapies that will be dosed even less frequently than that. So we will have options. And some of the options will involve novel targets of the virus that are not currently targeted. So understanding the basic biology of HIV is important, because if we understand all of the various functions and replication cycles, we may identify new targets, as has happened over time. On the PrEP side, for years we had basically daily PrEP option with the variants of on-demand PrEP, but fundamentally the same thing. We more recently have an injectable PrEP option with cabotegravir, which can be given monthly or bi-monthly. But that's changing as well. So the field is absolutely moving. And having referred to being on the ground floor when Margaret Fischel presented the AZT data back in 1986, I had the privilege of being at the International AIDS meeting in Munich last summer, where the Purpose 1 study was presented, and it was absolutely phenomenal. This is lenacapavir given as a subcutaneous injection every 6 months, and this study was done in African women, and it had a stunning 100% efficacy in this study. And at the conclusion of this presentation, the entire audience stood up and gave a standing ovation for a very long time. And that's a moment I will never forget. It's like if you were lucky enough to be in Vancouver in the arena when Sidney Crosby scored the gold medal goal, and I wasn't there, but my son was there. This is that moment in HIV medicine when that happened. This is just spectacular that we see. So we have come a very long way from dealing with hope and despair and dealing with the opportunistic infections, those that we could treat, to early generation non-suppressive antiretroviral therapy, then to complicated suppressive therapy, simple therapy now, and increasingly long-acting options and many more choices for patients. So we've come a tremendously long way over the journey of HIV, and I've been fortunate enough to be on the ground floor of it and watching it progress. So it's been a spectacular journey so far. It is now my privilege to introduce our next speaker, and that is Nadine Sukermani. She is the CEO of the OHTN, and she brings to us over 2 decades of senior leadership in the nonprofit, community health, and HIV sectors. So I look forward to hearing Nadine share her experiences with us.
Thank you. Thank you, Dr. Shafran. That was incredible to be able to walk that journey with you. Much appreciated. I've been asked by folks just to remind you that the Q&A QR code, it's the one of them, please scan, the one that says please scan the QR code, I believe, is that the one? For any questions you have along the way, and then we will, at the end of all of us, Patrick's gonna follow me, the questions will be shared and answered. I have notes. The reason is we had a very tight timeline, but we now have the space and grace to take things a little bit slower, so I am gonna slow it down a little bit, but please bear with me as I'm used to being in front of a college classroom with 3 hours at my fingertips to do whatever I want. And now, anyone in the room, many of you in the room know me, I can tend to be a bit verbose. And as much as I work to be humble and listen more than I speak, when you give me a room of folks like you to stand in front of, the thoughts are just flooding through. So I'm gonna try to stay on track. As I do that, I'd like to start by acknowledging and grounding myself in where we are. And so I acknowledge the impacts of colonialism on the HIV epidemic in Canada. And I will talk a little bit about mostly talk about the groups that are most represented and disproportionately impacted. But the work that I do and we do collectively, and shout out to the OHTN team that are here, we have quite a large delegation and so proud of the team. We are involved in collecting data and reporting, and we're quite in that realm of the work. And so I'm reminded and have been reminded over the last couple of days the importance of data sovereignty. And I've heard in rooms, multiple rooms since arriving here, of the fact that Black, Indigenous, queer, trans bodies are not lab rats. And so I want to acknowledge that we are all people, we are all here in this in a collective orchestra and symphony to do this work, but it is important to name that. I also recognize the ongoing colonial systems and the existing structures of the healthcare system. And while, as we're here in Nova Scotia, acknowledging the distinct Society of African Nova Scotians and their contributions to the Mi'kma'ki territory, which is now known as Nova Scotia. So thank you, and I really am so honored to be here. Whenever I come to the East Coast, I'm reminded of the currency being born in the prairies has. So Toronto, you know, how many of us, there's so many Ontarians and Torontonians here. Whenever you say from Toronto, people are like, oh, Toronto. But when I kind of dig in a little bit and say, well, I was born and raised in Winnipeg, and you can't get more Canadian than that. And that my work really is grounded in community and community health. At the Village Clinic in Winnipeg and the Women's Health Clinic in Winnipeg, I realize, as well as a racialized woman and as a racialized queer woman, that importance of that currency in conversations about building relationship. Growing up in Winnipeg with immigrant parents, they were really focused on assimilating us into Canadian society. And that came with many lessons and lots of hard lessons of racism in the school system and being called names and, growing up as a baby queer, also having to figure out and navigate the intersecting identities that was in my body. But my parents gave us all kinds of lessons: ice skating lessons, swimming lessons, and piano lessons, which you'll see here. So hence my role in the orchestra as a pianist. I practiced. And again, anyone here who knows what it's like, most parents expect perfection, but boy, I tell you, Caribbean parents are special in that regard. And so there was a way in which that practicing and getting it right, and I named, being queer, we also were very active in the church. And so every other Sunday morning, I sat in front of the church and played piano with a captive audience. And boy, if you made a mistake, everybody noticed, especially my parents. So that perfection and that striving for perfection has been ingrained in me. And like our work in HIV, we haven't quite got there. We have not yet perfected it. Hence the 95, 95, 95 that we're striving for. In science, we're always working towards getting it right, trial and error. And that multiple trials, the ways in which we know we're not quite getting it right. And so as much as we hear about the progress we've made so far, it's important to keep in mind that there is a cost to doing nothing for that percentage of people that we have not quite met the needs of. 95, 95, 95 is a difficult goal. It's relentless. We need to be relentless. And in order to measure our progress, we need to reset those goals and reevaluate our methods. When we know something needs attention and we don't tend to it, how is this showing up? How is this showing up in our work? So we have a little exercise that we'd like to do together. You may have noticed on your table some little paddles, and they're quite small. Actually, they look smaller, they look larger online than they do in real life. So I didn't order them, but the team was saying they expected them to be much larger. So towards our 95, 95, 95, we're gonna start with the yellow paddles. If you could just grab all of the yellow paddles on the table and hold those up as high as you can. They're a little hard to see, but those are our yellow paddles who represent the undiagnosed. And those are, so everyone in this room is living with HIV. So we're 100% PHAs, people living with HIV. The yellow paddles are the 11% who are undiagnosed. Now we're gonna take a look at those red paddles. And if folks could pick up those red paddles. And the red paddles represent those who are not on treatment. Keep holding up the yellow, please, and the red. We want to see all of them up at the same time. Perfect. And then you'll take the green paddles, and we can hold up all of the green paddles. And the green paddles represent the 5% who are unsuppressed. Oh, sorry, there we go. I'm going to actually ask everyone to stand. Anyone holding a paddle, please stand up. I'm going to do a little movement. No, I'm just kidding. No movement. I'm not doing no yoga. Okay. So what you're seeing here is the 28% of the people who are a missed opportunity in our response. These are the 28% of the people who are not receiving what they need in order for us to get to our 95, 95, 95. Take a look around. Ask yourself, who makes up that 28%? Who is represented in that number? What is 100% of the 28% of the people that are standing up, that are all people living with HIV right now in Canada? You can sit down now. The data, and now there's a question about the data. Dr. Winston Husbands reminded us and others, there's a lot of issues with the data. But what we know, both from the data we have, which is also part of the problem, that we don't have all of it, but we also know anecdotally, and from folks who live who are in this room, who are doing the work, we know who makes up that 28%. Those are Indigenous people, African, Caribbean, and Black communities, trans and gender diverse individuals, cisgendered women, people who use drugs, migrants, refugees. And along with that, we have to think about and consider, again, I don't know, Winston, if you're in the room, I'm going to quote you again, the social indicators of structural disadvantage. We talk about the social determinants of health, but we also need to think about those structural indicators, which include poverty, homelessness, under and unemployment. And we know how those structural disadvantages impact each of those groups that I just named. I just mentioned the data. So as was mentioned, I wanted to bring our attention to, or was asked to bring our attention to, Sasha Van Katwick's research. So this is Sasha's poster. You can take a look at it. It is with the posters there. But Sasha also tells us a little bit of the story from an investment perspective. So Sasha Van Katwick is a senior principal economist at the Institute of Health Economics and has done a considerable amount of work and research around the issue of HIV investment. And Sasha's conclusions are there. It should be data and community driven, and that the diminishing returns can be reversed if we implement a targeted regional response. Now, he's talking about regional response, but what I'm talking about is targeted structural responses to each of the communities that I've named already. So if we're able to target with and we just saw the example with cisgendered women that was talking about the benefits, the 100% efficacy for that group with a particular treatment. But what about the strategies, right? The current response gets lost in the averages and the data, and we miss the mark because we're not seeing the whole picture. So this is Sasha's work, not mine, but if you want to take a peek at that poster, I think that there's a lot of really important information there. When we think about a targeted regional response, I'm going to go back to my birthplace, Winnipeg, Manitoba, and we know what's happening in Manitoba. I know there's some folks here who are, involved in the very targeted response that's happening there. And we really can't ignore what's happening in the prairies, but in particular Manitoba. So this is here, you'll see how the rates are showing up for Manitobans. Manitoba is like our canary in the coal mine. If we look to what they're doing, like giving 100 universal access through their Manitoba HIV response to PrEP and to treatment, then we can see how they're trying to get ahead. What I know about Manitoba also, it's a disparate province, it's a rural, there's many people that are living in rural areas, it's hard to get to the north, and there's high rates of HIV in Indigenous communities there. So if we were to pay attention, like Sasha's reminded us, but also what we know and what is happening in other jurisdictions, British Columbia is another example, and in Ontario, I could speak to what we're doing there. On my way in, I actually was, as many of us do, flipping around on social media, and I came across a statement. For those who are from Toronto, you might know Dr. Andrew Buzari. Dr. Buzari is a social medicine, population health expert in Toronto, and he writes, "We can't keep accepting that it's okay to provide care for only 80% of the population and write off the remaining 20% as too challenging." He's speaking about the healthcare system as a whole, but if we were to take his 20%, I would translate that to the 28% that we're talking about in the room that we just saw. And it pushes us to consider why we're seeing this response flatten out and how can we see the response increase and have some impact towards our targets. We need a tailored, responsive system. The 20% or the 28% is what we need to really focus on. We cannot claim we are an accessible system, because how can that be true when thousands who are positive, who are living with HIV, are unable to get the care that they need in order to experience the privileges and benefits that so many of you in this room have. We need to close the gap. Like how I feel about the piano and getting it right, I'm excited and nervous about the work we have ahead of us. The other cascade that I wanted to talk a little bit about that's related to this targeted response is the fourth cascade, quality of life. And Dr. Shafran made reference to it, and I know this is not news to anyone in the room. I like to see the cascade not as step 1, 2, 3, 4, but rather a circle where they each inform each other. And quality of life, in fact, needs to frame it all. And if we were to do that, this image actually comes from OHTN's partnership, and I don't know if Megan Young is in the room, but OHAS leads, this year will be the 3rd annual Indigenous PHA gathering in Ontario. And this is the visual representation of that time that we had together earlier this year on Six Nations. We must build relationships, we must build trust, and we really must continue to work with the elders and knowledge keepers in our communities in order to make that work move forward. Our response must be sensitive to pervasive anti-Indigenous, anti-Black, anti-women, anti-trans, anti-gay, transphobic issues, especially in the current socio-political climate that we're in. It must be interdisciplinary in nature. This is not only about providing benefits to individuals, but also preventing and mitigating harm. It must look at the societal and systemic issues that we are facing, and evidence-based responses rooted in this quality of life cascade or part of the picture must be done. Because our response is lacking, we need to resource more and resource better. Otherwise, we flatten out. We need to think about how to move that needle up. And when we think about in Ontario and other parts of the country, how do we measure quality of life? How do we know that this quality of life indicator is moving forward? But there is still hope. Our collective goal is to shine the light in the direction of those who are not getting what they need, that 28%. My call to action is to provide equitable access so we can focus on solutions and responses and not just sit in the numbers. The strategies we employ to get where we are now have not worked. They are not getting us to where we need to be unless we act now. The last 5% is the hardest due to the complexity and because we can't quite get it right. It's hard to get it perfect, but we must do better. There's room for all of us at this table. We need every part of the symphony to get to the end of the performance, and I know that we can get there. With Jipa Mepa in mind, and as Rosemary Brown, the first Black woman to sit in provincial legislature, reminds us, until all of us, none of us. Thank you. And I have the absolute pleasure to welcome to the stage Dr. Patrick O'Byrne. Patrick is a professor of nursing at University of Ottawa and a nurse practitioner at the STI Clinic in the city of Ottawa.
Thank you, Nadine.
Thank you.
Thanks for the introduction. As Nadine said, my name is Patrick O'Byrne. I'm a full professor of nursing at the University of Ottawa, and probably more importantly, at least for me, I'm a nurse practitioner in the STI Clinic in Ottawa. I've worked there 22 years providing frontline clinical services, and every time I come to talk and about any of these things, I always think like it's a reflection on what has occurred in those last 2 decades. And the reflection, I think, really to summarize it down is, right, where are we now? Where have we gone? Where have we come? We've had a walk through the timeline. What have we done? We've gone from, right, people being diagnosed, absolutely no hope, medications that went from many per day down to single pills, long-acting pills. We've moved into injectables that are, right, twice or every 2 months to twice a year. Right? These are incredible advancements. Testing, we have revolutionized testing. We've gone from window periods that were months down to 6 months, down to 3 months, most recently down to 6 weeks. Right? We have moved into point-of-care testing. Point-of-care testing that is now just an incorporated component of clinical practice. Somebody who can come in, they're transient, they're symptomatic, they have recurrent thrush. We can do a point-of-care test and diagnose, right, with very good certainty at the point of care. And only recently, right, we have deployed self-tests coast to coast again, putting, right, testing back into people's hands. For better or for worse, we have moved testing in many different ways, and we have really shifted that needle forward. We also have prevention changes. Daryl was talking about this morning. We have gone from, right, it's use a condom, right, sort, get tested every 3 months, and let's, right, just see what the test result comes back to medications that can be taken daily as 2-1-1 regimes, and we're moving into injectables every 2 months, and then again, right, every 6 months. These are remarkable changes that we're actually looking at. But on the other hand, 22 years of clinical practice, what do I see? People coming in continuously and being diagnosed. Rates going up, ongoing stigma, ongoing criminal prosecutions, right? The same groups continuing to be affected. And so I say, yeah, we do have all of these remarkable, absolutely remarkable advancements in our technologies. We have collectively worked and brought ourselves forward a massive amount, and yet my daily practice, day in and day out, is unchanged. And so the reflection I came to is, while many things do seem to have moved forward, nothing seems to have actually changed for me. Patients, right? I will illustrate this point with 3 patients. These are real patients that I have seen. Faces, names, details have been obfuscated, so we don't actually identify anyone. But this was 2 weeks ago. This 20-year-old black man came in. He'd done his testing. The chlamydia urine test was positive. The blood tests were still pending. And I said, right, so we were going to treat the chlamydia. He said, yeah, I got the notification, right, that my test results were available online. I looked at it, and it said chlamydia. And he's like, great, I can treat that one. I can deal with that. He's like, but my HIV results, I'm really stressed about this one. And I know if I get that, I'm cooked. These are his exact words. If that one comes back positive, I'm cooked. And I said, well, what is the big concern you have with it? And he's like, well, I had sex with this woman, and she's got AIDS. I was like, okay, let's unpack this a little bit. What do you mean she has AIDS? As in, she told you, right, she's been diagnosed with HIV? And he said, no, she has sex with a bunch of people, and my buddies told me she has AIDS. She does not have AIDS. She does not have HIV. What we're using here in the language, and so we talk about we've advanced, we've made social change, stigma is decreased. Effectively, we still have AIDS, HIV used as the pejorative term for slut shaming. That's really what this comes down to, right? That has not changed. The stigma is still there. So I said to him, did you know, right, if the HIV test does come back positive, because it was still pending at the point that I saw him, I said, did you know if this comes back, we'll give you a medication. You take a pill every day, maybe an injection every few months. Right? And undetectable equals untransmittable. And he said, I can still fuck. I was like, yes, you can. And so I texted Randy, and I was like, Randy, we thought we were clever with U equals U as a snappy thing, but this youth has come up with a better phrase for us. I can still fuck, right? This is what we need to start putting on buses. We'll probably get in a lot of trouble, but nonetheless, right, he's taken U equals U and made it better. His eyes widened. He was like, this just absolutely blew his mind. But what were we looking at? Stigma, ongoing. AIDS, she's a slut. That's what that meant. That's what brought him in. Awareness, we think U equals U, right, is pervasive knowledge. I see very few patients in the STI clinic who are aware of that. We have concentrations of knowledge, small pockets. This is not the vast majority of people. And knowledge, whether it's our school systems failing us or society, whatever it is, right, just understanding of STI, HIV transmission prevention, all of these different things, we're not doing a great job. So again, I go back to, we have advanced these things, and yet I don't see any differences. Next, we have a mid-30s, urban, white guy who has sex with guys. I was seeing him on Monday morning, this in fact past Monday morning, like still in the same week as this. I said, what brings you in today? And he said to me, really stressed with work. He's an urban professional. He does not have any extended health benefits. So he's got in Ontario, we call it the Ontario Health Insurance Plan, OHIP, BC CAHR, right, all of these different things. So he says OHIP, but he doesn't have anything to pay for medications. So I said, right, what brings you in? He's like, I've been really stressed with work. I wanted to relax a bit. I had a couple drinks, and I went to the bathhouse. I was like, how did that go? You're here to see me. Must be something, right, eventful that occurred. And he said, I think I got a bit more relaxed than I'd intended to, and I bought him for a whole bunch of guys. Number, I'm not entirely certain. So I was like, okay, first point of business, did you enjoy yourself? He said, yes. I'm like, well, this is good. We're off to a good start. I was like, second point in business, we are under 24 hours. You are in the STI clinic, right? Let's talk about PEP. He said, that's really what has brought me in. I said, yes, you absolutely meet the clinical indication for PEP. Right? You had multiple partners last night, condomless, receptive anal sex, unknown HIV status. sure, right? There's absolutely no reason why we wouldn't actually give you these medications. And I said, but I don't have insurance, and I know these cost $1,500 to $2,000. He said, yeah, the shelf cost is going to be around $1,500, that's right. And so his main question was not, do I have a clinical indication? Will there be side effects? Can I take these? What's the follow-up? His question to me was, but is it worth me not paying my rent or buying my groceries to go on these medications? And so what we're looking at again is ongoing financial barriers, right? We in fact potentially create worse inequities by saying we have these powerful interventions, but they're only for the haves. They're only for the people who have insurance, right? It works exceptionally well if you can afford it, right? And that's really what his question to me was. And he said, at some point, right, I used to actually do some volunteer work, and he's like, I still don't know if I can, like, volunteer work in HIV and AIDS work. So I still don't know, right, if I can afford this, how I'm going to take this. And he's like, I guess I just have to do it. And he's like, or maybe I don't, and I'll test positive. He's like, and then I'm going to have to decide if I'm going to try to figure out like public funding on my own, right? Be too proud to actually go and ask for help. He's like, or am I going to become the person that I used to try to connect to drug benefit programs? Am I going to be able to keep working, or am I going to have to actually go on public assistance to get my medications paid for? Now, fortunately in Ottawa, we do have a publicly funded PEP program through the city of Ottawa. So we said, no, you're uninsured. We will ensure you have access to the full course of the medication, right? And the entire thing was paid for. So we moved it forward, but only due to a niche project. That's really what we're looking at. Third patient. Now this is actually going back to around 2001. This one isn't as recent. So this woman was 30-ish. She is HIV positive. She was living in a trap house. So she had just recently sort of relocated to Ottawa. She was living in a trap house. So how do I come involved with this person? She tested positive for syphilis. She's pregnant. She's actually around, I think it was around 30 weeks pregnant. She newly tested positive for syphilis. And to make matters worse, she tested positive for COVID with a variant of concern, 2001. So we're trying to figure out how to get her treated. The hospital protocols at the time, unfortunately, said you have COVID with a variant of concern, and she couldn't even get through the administrative booking processes. So I can't get her into the hospital to have treatment, right? We need this. Syphilis is resurging. Congenital syphilis is becoming a major concern. I can't actually get this person treated into the hospital system. She doesn't have a car. This is very clear. So we're like, maybe we could pay for a cab or an Uber. We're like, no, then we're going to needlessly expose somebody who has to work, probably won't have paid sick time, to actually bring her into us in the STI clinic. So, I don't know where she is. Lauren Orser is one of the nurses who works in the clinic. She just said to me, we have to go and see her. And I was like, yes, we do have to go and see her. So we packed up our anaphylaxis kit and our benzathine penicillin G and our PPE, and we drove to this trap house in the manager's car, and we put on our PPE on the street, probably looked like E.T., right, in that like closing scene, and in we went. Tiny little, very dirty mattress. We injected our Benpen-G right there. We gave her treatment, and we sat with her for 15 minutes. I'm gonna add that this was also August, and there's like this tiny little window, and it was so bloody hot that when I left, I had to buy a new shirt before I went back to work. Like, we just sweat through absolutely everything. But what it showed us is the healthcare system barriers have not changed, right? People say, right, there are hard-to-reach populations, but really what it is it's the hard-to-reach healthcare system, right? That's specifically what we're looking at. And when we put in the effort, and when we actually go out and we listen to good, innovative ideas about how we can actually take healthcare to people, right, we can actually get treatment done. And in this case, right, this baby was not born with congenital syphilis. 4 years out, we still have no signs of it. This is potentially, it never would have occurred, but I think this is a success story and probably one of those cases that was averted due to nurses saying, let's actually go see our patients. And they're saying, yes, right, let's actually go along with this. This seems like the most reasonable approach. So again, things have changed, right? We've talked about all these advancements. PrEP, too. One of the things I should have mentioned earlier is just like task shifting. We have moved this from infectious diseases into actual registered nurses at the front line being able to do this. Incredible changes that we've come across, that we've developed, the innovations that we've actually implemented, but many barriers still exist. So the takeaway for me, to maybe have less despair, is we're not at the beginning, but we're not at the end. This is not the time for us to actually relax and sit back. And just sort of as the final point, I want to take a newer campaign in Ontario that is No HIV, K-N-O-W. No means know as in understand, right? Know the virus, know viral transmission, know how prevention works, know how treatment works. But it also means know and empathize the experience of feeling at risk, of having to go in, the humility that it takes to say, this occurred, right? I need to actually seek help. Empathizing with the experience of being diagnosed, right? Empathizing with the fear of discrimination, of exclusion, right? Of criminalization, knowing that. But it also means know as in N-O, right? No more transmission, no one without access to free PrEP, no one who has to come and see me and say, am I going to have to forego my food to take PEP, right? And really, no one without access to treatment. So this is no one left behind. We have set 95 targets, and those tell me we are all comfortable leaving 5% behind. Hep C has said elimination, and we have said we don't care about the last 5%, we want to get closer. Hopefully next year, we reconvene in Winnipeg. Somebody else can stand here and say, we have in fact moved forward. The narrative is changed. We've decided that 95 is no longer high enough. We want to go for 100%. Again, no one left behind. Thanks for having me.
Thank you, Patrick. Stay.
I stay, right.
Yes. Thank you. Wasn't that just excellent? I'll invite our speakers up onto the stage. And I'll just tell you that Steve gave a wonderful presentation on the antivirals, where they came from, where they are, and we're moving with long-acting injectables. That's really going to get us to our goals. Sasha, that wasn't here, talked about data management. Well, he didn't really. Thank you, Nadine. Sasha would have told us about data management and targeted therapeutic responses, which Nadine then so nicely showed. Premier Ward Kinu of Manitoba's response. That was excellent. And then lastly, Patrick showed us that even if we talk about numbers, it's really about the individual patients and the barriers that they experience to treatment. And I really like the way you ended. 95 is not good enough. So questions and answers. You have your Slido. The Slido, remember, is the QR code with the 4 goals of this talk. Is the QR code that you use. Please, and there it is on the screen. Please use that and send me questions. I'll start with the first question for Steve. Okay. Steve, what do you think about where does CURE fit into our targets?
Well, the question is, where does CURE fit? Well, I mean, who could be opposed to the idea of curing almost any human illness, HIV included? So sure, that would be fantastic if it can be done. So far, we have not been successful. Okay, I will acknowledge there's this growing handful, it's still less than 10, of people who ended up with an HIV cure because they had a hematologic malignancy requiring a bone marrow transplant, and they happened to get a donor who lacked the co-receptor for HIV. But of course, bone marrow transplant means you're on immunosuppressive drug. You have all kinds of other baggage. That is not a scalable option, okay? So if you take that off the table, we don't, I don't know when we're going to see cure. It would be fantastic if we did. And I will say there would be a bit of a difference between cure with immunity and cure without immunity. Let me explain, because if you could cure, when we cure people of Hep C today, we cure them without immunity, and a subset of people who get cured of Hep C will get another infection. That does happen. So if we have a cure magically for HIV tomorrow, there'll be a subset of people cured who are at risk of getting HIV again, so they'll go off whatever their HIV regimen is, they'll take this mystical cure, and some of them will actually have to go on PrEP. So it kind of depends on what their situation is and their lifestyle. But I mean, you can't be opposed to cure, and you never know if it's going to come. So that's certainly, I would say, there's 2 pieces of the HIV treatment puzzle that are completely missing. One is a true cure, and the other would be a preventative vaccine. I mean, our PrEP is so good, but the challenge now with preventative vaccine is, how would you ethically study it now? Because you couldn't take a high-risk population and not offer them the best prep that we have from an ethical perspective. So even if scientists come up with a candidate vaccine, I think the logistics of testing it are going to be extremely difficult.
Yeah, I agree. The lenacapavir every 6 months prevention is definitely a game changer. But a preventative vaccine will be fantastic, especially if it's just one shot forever. Well, who knows?
Yeah.
Nadine, thank you. That was a spectacular talk. You ended with a slide on hope. Do you see a harbinger of hope for us?
Of course. I mean, we have to hold on to hope. I was reminded as I came back to the table that I forgot to mention that my name means hope. So that was how we ended with that. There are a lot of targeted strategies. Manitoba is that really good example. In Ontario, we have under modeling Dr. Natisha Masakai's work. I'm not sure if Natisha's in the room. Really clinical interventions with Black families. And at the OHTN, we have the absolute benefit and privilege to work with organizations, community health centers, practitioners, not only clinically, but also, again, back to those social indicators and structural indicators. When I think about how we do the work with Indigenous communities and, again, all of the groups that I've mentioned, the idea that we can go to community and ask them what they need and really respond in that tangible way. I actually was having breakfast the other morning with Dr. McCready, and again, I don't know if Lance is in the room, but we were talking about engaging in some work. We know the traditional healthcare system isn't working, as Patrick mentioned. That system is broken. It is not getting to that 5% that we need to reach. We need to think differently about that, not just clinical, not just healthcare, but that social systemic approach. And I think all of the messaging today really pointed to that. And that's where I hold hope, that we're listening, we're responding, and we're acting.
Thank you. Patrick, thanks for reminding us that we really need to be at 100% and not at 95% or any other number. Patrick, moving forward, what does meaningful community engagement mean to you?
I like this question. I'm going to start with, yeah, I planted it. In the 80s, public health workers shut down bathhouses.
Say again, sorry.
In the 80s, public health workers shut down bathhouses. They said these are locations, loci of infection and transmission, and we need to go and close these hotspots down. In 2022, we had Mpox. And working right through the public health unit, the AIDS Committee of Ottawa, Max Ottawa, two of our local AIDS service organizations, we set up an Mpox pop-up in the bathhouse. And it was really guided by community to say, we're going to show up with the vaccine and staff, and we're going to store this vaccine in a very hot, steamy place and make sure it's fine. You're going to bring people in. And it's a very big change to have this community guidance to say, we're going to shut down this space, to say, this is the space that you find is safe, right? This is the space where you congregate, and this is the space we're going to go in and provide healthcare services. In that Mpox vaccine pop-up, we actually vaccinated more people in the city of Ottawa than we did in our first fully public health run COVID vaccine clinic. That's how successful it was, based on community actually bringing people in and engaging them. As a second thing, I think I was recently at an event at the AIDS Committee of Ottawa, and I saw researcher after researcher after researcher stand up and say community engagement, and it was almost like a buzzword and a tick box. And I was like, and yet when you publish, these community people are never on your papers. And you never come to these events to actually share. I was with Khaled, from ASO all the time, Adam from Max Ottawa all the time, going in, presenting, doing services, helping people get connected to testing. It's not just about using it on your grant applications. It's about actually going and giving back. This is through knowledge translation, but actually service delivery.
Thank you. Steve, there's a question here about 6 monthly injectable medications, and how does a huge dose of something that has to last 6 months not have side effects?
Well, I think I don't think there's a medication yet that doesn't have side effects in at least some people, right? Each drug has its own properties, and some have, side effects in high proportions of people, and some have it in lower. And, so lenacapavir is obviously the candidate drug, but that would be true of any. Yeah, there's a percentage of people who are going to have side effects with anything, and I guess is the concern that the drug is going to sit around for a long time. I guess we'll have to wait as the usage gets bigger. I mean, there have been thousands of people treated in the various trials to date, and the tolerance has been high, and the discontinuation rates have been extremely low. But there's going to be some side effects with any medication. It does raise the issue is since there is an oral version, do you want to give somebody a trial of oral for a little bit? But that sits around for a long time too, just less time. So I guess we'll have to see over time how problematic this is. But I don't think I think it'll be a problem in a very small number of people is what I expect to see.
Thank you. Nadine, there's quite a few questions about the inequity of PrEP coverage in our country, that in some provinces it's free and some it's not. And the question is really, should we advocate for a national universal drug coverage for PrEP, or in fact actually for treatment? Because in some provinces you actually have to pay for HIV treatment as well.
Well, absolutely. Again, I think I'm going to go back to Dr. Bouzeri's statement, right? When we talk about a universal healthcare system, are we really truly universal? And I think it's also really resonant in what Dr. O'Byrne talked about, that we are not reaching everyone. I think a universal treatment and access to PrEP, and beyond that, beyond HIV, like really open that up as wide as we can, we will see health outcomes increase and that quality of life, back to that cascade and that description. If we can increase the full picture and fill that up and people are part of that picture, I think universal access is part of it. A national or federal response is needed. I know many provinces are getting closer, those who have not already done it. We're getting closer and closer to it. But yeah, we definitely need to work across the country.
Thank you. Sort of lead into that is, Patrick, PEP seems to be free in some provinces. Can you expand on PEP access in Ontario?
PEP?
PEP.
Post-exposure? You have to go to eMERGE. That's really what it comes down to. Ottawa has the clinic-based, right? We have a nurse-led PEP clinic that we set up in 2013. But beyond that, it really is restricted to emergency departments. And so you have to do whatever you've done and then decide that you want to go to eMERGE, sit through that process, probably speak with clinicians who are far less experienced than we are in an STI clinic, and they'll give you a starter pack. And the starter pack will probably be covered, but paying for the rest of it is going to come out of your insurance. Ottawa is unique. We did have incredible leadership from our medical officer who looked at the numbers and said, you're bringing in a lot of people. You are actually preventing a bunch of cases. We actually, at the beginning, were diagnosing almost 10% of people who were coming in seeking PEP with HIV. This was not a new infection. This was a historical infection, because a lot of I think, so that's the funding part, but just as a tangent on PEP, is most of our HIV prevention work right now says, you think you're HIV negative, right? But you may not be, or you may be at risk. And being HIV or positive or negative is not just a status, it's an identity, right? If you've ever been diagnosed with a chronic disease or anything, you have to grieve, right? The loss of your former self and move into that new thing. So you say, no, I'm an HIV negative person, I'm not at risk, why would I need these prevention things? But PEP is unique in that you say, most of the time people will say, something exceptional occurred. right? And so this is a deviation, and I want to protect my identity. I want to stay HIV negative, and so consequently, I'm going to use this. But the financial barrier is so high, the access barrier is so difficult that we have this exceptionally powerful way to bring people in to then link them to PrEP, but it is inaccessible, it is unaffordable, basically everywhere.
Thank you. Yeah, I was surprised about that because in BC, where I work, PrEP is, of course, free. It's a necessity. So I think that speaks to the fact that we don't have a Canadian response, and every province has its own individual health managements that decide by themselves. I have a lot of questions about that. And one question, but the question I specifically want to lobby at you, Nadine, there's a disturbing question here. As part of the 5%, I'm constantly asked if I will sign a do not resuscitation order. Are these points being looked at and addressed? So this is like a very disturbing question to me. And do you want to take a go at that?
Well, I mean, I can't speak to an individual. I'm all about autonomy and individual choice. And the idea that someone would ask that actually speaks to, and I imagine it's in a clinical setting, or wherever that's happening, to me that's, again, back to how are we seeing who is made up of that 5%? We are actually devaluing certain people's lives and value in the system. And that, you know, it's also like, you know, when older folks are getting to the end of life, you know, I think of a COVID pandemic, for example. At the beginning of the COVID pandemic, when we heard it was disproportionately impacting older folks in long-term care, most people were like, oh, I'm not part of that group. That's, you know, not going to affect me. And I think this is also to some of the things we're talking about here. What is under that question? And that, to me, is stigma. That is fear, and that is a devaluing of that individual and what they give to us and what they mean. The fact that they have a community around them, they have people who love them, and that is not really within one's purview. So I would encourage people to utilize their voice, bring people with them to their, you know, appointments, and have someone speak for you if you're, you know, unable to do so for yourself for any reason. I think that we just need to advocate and systemically across the system stop that practice. That's absolutely unacceptable.
And I think that was exactly also Patrick's talk. We have to see, we don't really treat numbers, we treat people.
Yeah.
And we have to look at each individual person in front of us and see what their barriers are so that no 5% get left behind. I think on that note, that's like a very powerful note. I think you can go and get a bit of fresh air till the next meeting start. I want to thank Neil and the Gilead team for arranging our symposium. Specifically thank our team here that did such a fantastic job. And of course, the video and AV people, Jeff and his team, for making all of this possible and giving us our orchestra music theme. This is your evaluation, QRS. There's been so many QRSs, I'm confused. But this is the one that you're supposed to fill in to tell us if you liked it. And then lastly, on the other side of your flyer, it'll say, scan this code if you want to be part of the skills program on advocacy capacity building. It's complex. There's a lot of words here that I didn't get right. So let's try over and not stumble. Gilead is going to have a skills program on advocacy and capacity building. If you're interested to find out more about that, scan this, put your name up, and there will be a program rolled out to help us build more capacity. And so that's our QRS code for evaluation. Thank you so much, everybody.